Hello, everyone. Welcome, everyone, to the Health for the World question and answer sessions. Dr. Dean Winslow. Hope all the healthcare professionals who have joined us today are keeping safe. These are hard times, but we hope to fight through this pandemic together as a global community of healthcare professionals. I'll start with introducing myself. I'm Dr. Bhavya Rihani. I'm the co-founder and president of Health for the World, which is a nonprofit initiative. We aim to promote health in low-resource settings globally using education and technology. We are a global community, and many of the doctors who we work with have been able to join today, and thanks so much for doing that. Next, I would like to introduce Dr. Bill Dillon. Dr. Bill Dillon is the Executive Vice Chair of Radiology at UCSF and also the co-founder of Health for the World. Also, we have Dr. Ankur Barija here, who's a co-founder of Health for the World and Director of Inpatient Geriatrics at Stanford. Ankur will be doing the moderation for the question and answer sessions with Dr. Winslow today. And finally, I would like to welcome our esteemed faculty today, Dr. Dean Winslow. Dr. Winslow is a world-renowned infectious disease expert at Stanford. He's a professor of infectious diseases. He has practiced medicine for more than 40 years. Dr. Winslow also has a special interest in bedside teaching of medical students, residents, and fellows. Dr. Winslow is also the former vice chair of medicine at Stanford University. Dr. Winslow has been very kind to take out some time during this pandemic to answer the question and answers, to answer questions which were posted from the healthcare professionals on Facebook as well as submitted on the form. We will start with the question and answers which were submitted by you guys, and Ankur will address them. The format would be simple. It will be a question and answer session. Ankur will be asking the questions which were submitted earlier. In the end, we can address the questions which you have, which you were not able to submit. I would suggest you can submit the questions in the chat format at the bottom of the screen so that we can make a note of those and address this towards the end. Thank you so much and welcome everyone.
Well, Ankur, before you get started, I think for the benefit of the group, I first of all want to thank you and your other co-founders of the organization for inviting me to participate in this. It really is an honor. But just for the benefit of everyone, I want people to know that Ankur is one of the best clinicians that I've ever worked with. And again, I attend a lot on the wards at Stanford, and I'm grateful for that Ankur, gives all of us, particularly for the care of our geriatrics patients. So again, Ankur, thank you.
Well, Dean, it's an honor. I remember meeting with you within the first week when I started at Stanford. So I always look forward to working with you, and it's really an honor to call you a colleague and a friend. So I am really pleased to share you with the audience, take out the wisdom and experience from you, and let's really jump into it. I know this is a critical moment for everyone as COVID numbers keep on going in the scary direction, and things are evolving, and we're all learning on the go. Thanks, Dean, once again. Thanks, everyone. Some of you we know for over 2, 3, 4 years, and some of you over a few days. So welcome to the new friends of Health for the World. All right, so we've sort of compiled a list of topics from the questions that we've been getting from our registrants over the last week, and let's jump into the epidemiology and basics a little bit as we start about this. Everyone's worried about transmission. Obviously, we know it came from Wuhan initially as a zoonotic virus, and now person-to-person rapidly spreading. Dean, can you elaborate a little more around sort of the spread, the transmission, whether, confusion around being airborne versus droplet, and of course, some reports of it being fecal-oral as well?
Yeah, so, again, as you very nicely said, that the virus itself is an encapsulated RNA virus. It's considered positively stranded. That has to do with the transcription cycle, and it's very closely related. It's actually in the what's called the beta coronavirus family. So it's the number non-human pathogens, as well as the original SARS coronavirus that caused the outbreak in 2002, 2003. So again, a lot of antigenic similarities to that virus. As you mentioned, I think the natural host for this is probably the wild bats, and then it appears like this particular virus was amplified in certain small mesomammal intermediate hosts, and the pangolin is one that's been postulated. And again, this is a kind of an exotic meat that's very highly prized in Asia. So it's speculated or postulated that this pathogen made the jump into humans was by these wet markets that they have in China. But again, a lot of that is kind of circumstantial evidence. So most of the evidence, clearly supports that this virus is primarily transmitted by fairly large droplets, greater than 5 microns, I believe, in diameter. And again, there's some evidence that smaller micron-sized particles, which of course would require potentially more intensive protective personal protective equipment. Although interestingly, there was a case report just last week in the Annals of Internal Medicine of a patient who was very, very acutely ill and underwent emergent intubation, and there were about 8 healthcare workers, I think, that were very heavily exposed, and some were wearing really just minimal surgical face masks, and others had N95 respirators. And none of these individuals that were involved in the care of this patient, who again, it was apparently a very traumatic, difficult intubation, and none were infected. So there's also, I think, some disinformation that's kind of being retroactively issued by the Chinese government, in that they're kind of reinventing history. And there's a number of videos that have been circulating. I think many of you have seen them, showing now, Chinese doctors and nurses literally being dressed in spacesuits with full respirators and things like that, which obviously wasn't what they were doing originally. And some of this is being spread actually by Russian bots. There was an article in the New York Times that to kind of create sow chaos and everything in the West. The other way that the virus clearly is transmitted, because it can persist for up to 48 or 72 hours, although in relatively low titers on surfaces such as plastic and stainless steel. So that's the reason behind the frequent hand washing and trying to avoid touching your face, because of the fact that infectious virus certainly can persist, at least for a while, on environmental surfaces. So those are kind of what we know at this point about the way the virus is transmitted.
Okay, thank you. So essentially droplet, and I know there's recent sort of experimental reports around it being aerosolized and can stay in the air for about 3 hours. Would you want to comment on that?
Yeah. So again, I'm not an expert that aspect of viruses, but it's, as you point out, it can possibly stay airborne in situations where you would have very, very little airflow. So that's one reason why, if at all possible, we like having these patients placed in negative pressure rooms, where there is adequate airflow. And we're also recommending at Stanford, of course, that patients who are confirmed positive for the SARS coronavirus to COVID-19 infection actually wear a mask when they're in direct contact with a healthcare provider in the same room. But again, as I mentioned, at least there are these anecdotal case reports that are out there that show that the particle droplets rather than these microaerosols. Okay.
Would you elaborate on the there was questions around infectivity? How infective is one early in the disease? What about asymptomatic carriers? How much should we be worried about infectivity there?
Yeah. So, from what I've been able to gather from the literature, and again, with the caveat that there's not been the availability of widespread testing. So we really haven't looked at kind of serial swabs with quantitative RT-PCR from large numbers of patients symptoms. But what we do have is that people can shed virus for probably not much more than anyway than 24 to 48 hours prior to developing symptoms. And then the viral titers in nasal secretions and oropharyngeal secretions are much higher in the first couple of days of illness. Usually by the third day of illness, the data I've seen, the small numbers of patients that have been examined serially by RT-PCR show that the virus titers fall off very quickly after about the third day.
Okay, that's really helpful. Let's jump into some clinical questions we got. Can you comment sort of in general around the clinical presentation that we're seeing, most common presentation and the course, sort of clinical course these patients are taking?
Yeah, so again, I did, haven't personally cared for very many of these patients. So we've had, though, a little over a dozen, I believe, at Stanford to date, and I'm sure you're maybe even more up to date on that than I am at this point. But majority of patients, have presented with fever, cough, chest tightness, some upper respiratory symptoms, but that's not quite as prominent apparently as in rhinovirus infections or some other common pathogens that cause so fever, cough, shortness of breath, chest tightness have been the big ones that they've seen. There was also, again, kind of an interesting report that my colleague at the VA, David Relman, sent me last night, showing that anosmia, or difficulty smelling, may be a fairly early symptom that could be potentially useful in differentiating this from other infections. So again, I haven't heard that from other sources, but again, that was something that was just circulating late yesterday.
Okay. Any and we know sort of on all lab tested patients who test positive, generally 5% needed ICU, and studies now showing 80% have had mild symptoms across the population. When we sort of look at the higher risk groups, though, we know mortality in 80 plus is much higher, almost 20% in some studies from China, as compared to 1 to 2% in the overall population. Do you want to comment? Could you comment on the sort of long-term, or we don't have much long-term data yet, but on the morbidity around older adults who recover from the illness?
Yeah. So again, we really don't have that much experience, looking at, how quickly lung function, for example, recovers in these patients. But I know, it's patients ventilators for some time. The article that I saw just a few days ago in the New England Journal from the large university group in Wuhan that actually had autopsies on a number of patients. What they showed, not surprisingly, is a kind of an evolution in lung specimens, depending on when the patients had died in the course of their illness, between kind of acute inflammation and then eventually people who died late in the course actually had some degree of fibrosis, it appeared. So again, how permanent that is, I think it's a little bit unclear at this point. So again, I'm just not aware that we have enough data about the long-term effects of this pathogen, on lung tissue.
Sure. There was some concern, some questions around special sort of high-risk populations. What precautions or measures can be taken? Those with chronic illnesses, those with low immunity. One question mentioned people with one kidney, and so forth. So sort of general theme around protecting those who are at highest risk.
Yeah. So, again, it's a, great question. And I think just general advice, and this, is not really particularly evidence, I think just for common sense. Individuals are older and that have underlying chronic disease. And so, again, going back to the Chinese experience that's been published, individuals with underlying diabetes, hypertension, coronary artery disease, I believe CKD, chronic kidney disease as well, all appear to be at much higher risk for adverse clinical outcomes. I don't think necessarily they're more prone to infection per se, but certainly the adverse consequences and mortality rate, appeared to be much, much higher in these individuals, as well as you very accurately mentioned, individuals over the age of 70, certainly have, at least in most of these studies, have had mortality rates at least in double digits, as you point out. So I think, again, it just makes sense for folks, who are older and have underlying diseases to really take seriously the shelter-in-place orders like we have in California, and certainly, until the transmission in the community falls significantly below what it is right now, it makes sense for people like that to be really, really careful. And speaking a little bit, my mother just turned 91 recently, and she's in an assisted living facility. And so I had to give her a stern lecture last week before they put restrictions on everyone to well, not to stay inside all the time. Certainly, we encourage people to go out and walk and and stay active and everything, but certainly not participate in large group activities.
Great, thanks. We had a follow-up question around those who decline and end up on a ventilator. Over what, if this is in your purview, and over what time frame do those who go to ventilator care decline?
Yeah. So again, it's quite variable. Some individuals have actually appeared to initially improve and then deteriorate. Sometimes 2 or 3 or 4 days into the illness. That was reported in China, as well as in the Italy experience. And I believe even one of the patients at Stanford kind of followed that path, appeared to be initially improving and then deteriorated and actually required intubation with mechanical ventilation. But I think it's quite variable. But I think the more concerning thing is that individuals sometimes require very, very high FiO2 settings and positive end expiratory pressure settings that very difficult to maintain. And of course, ECMO, or extracorporeal membrane oxygenation, is a very, very precious and resource-intensive procedure that even wonderful Stanford, in terms of the number of patients that we could support with ECMO, if indeed they require such high FiO2s and PEEP pressures that they cannot be maintained on mechanical ventilation.
Right. Thank you. Those sort of another special population that is people are worried, of course, are children and kids. We know that the rates of significant disease in this population is not high. Any other comments with your from what you found in this?
Yeah, and again, we're really not widely testing children, at least particularly asymptomatic children or minimally symptomatic children. But as you point out, that when they do become infected, they tend to have much milder disease. I think one of the positive things also is there have been very few, if any, that I'm aware of, documented instances of children transmitting SARS coronavirus to their parents. So I think the decision to close schools in many places is certainly prudent. But again, I think that the children are not the main vectors, so to speak, for transmission in the community.
Great, that's reassuring. Let's move on to testing a little bit. Can you share about the test that is currently available? And there was another question around testing was, how was the decision made to not use the COVID-19 test provided by WHO in the United States?
Yeah, and I don't know, all of the details around that, Ankur, but I know that the WHO assay and I believe the CDC assay as well, they use as the target for the PCR primers a region of the nucleocapsid genome or gene coding sequence. this initial assay it was adopted by the CDC. There were some problems with reagents that delayed the rollout for a while. Meanwhile, at Stanford, we were very lucky. One of our colleagues, Ben Pinsky, who I imagine you've probably met, who runs our diagnostic virology lab over by the VA, had already, based on the published sequence of the SARS coronavirus 2 that was released, I believe, in late January, really quickly developed a very nice PCR assay on his own using the envelope, regional envelope of the virus. It's a very, very high sensitivity and virtually 100% specificity as well. So he was actually able to scale that up early in February and had a lot of experience with it even before it was officially approved. There was also, from what I understand, and again, in a previous life, I actually worked as a VP of regulatory for a diagnostic company, and this is like 20 years ago now. But one of the things that I think slowed the rollout of other laboratory developed tests was that even though the FDA can actually waive its discretion to regulate laboratory developed molecular tests, there's this exception that in the setting of outbreaks that they actually want to see the data and actually approve the test almost like they would a formal clearance of an in vitro diagnostic device. So that was another thing that was brought up as potentially slowing at least the development of laboratory developed tests by Mayo Labs and LabCorp and Quest, some of the big commercial laboratories that we have here in the US.
Great. Well, we'll come back to sort of special scenarios. I know there's questions around when testing isn't available or there isn't enough reagent. We'll cover that sort of in health system preparedness. But moving on to treatment, we know sort of it's mostly supportive, and there was specific questions around sort of your opinions around the use of chloroquine, and azithromycin, and all kinds of anecdotal sort of things coming out.
Yeah. So again, my understanding is the mechanism of action of chloroquine and hydroxychloroquine, which of course is commonly used for treatment of lupus and other rheumatic diseases here, is that by affecting, I think, the pH of the membrane vesicles, which are required for assembly of the virus, that has in vitro activity in cell culture. So far, there's really just not enough data from prospective randomized controlled trials to really show that chloroquine or hydroxychloroquine really works. And so I think that's one reason why it's very, very important that we complete these trials, which again can be very, very short term. So I'm, personally, reserving judgment on using them until we actually see some early clinical data from these trials, which hopefully should be forthcoming, in the next couple of weeks. Remember, though, these drugs are really not completely benign, and activity in cell culture assay can often be very nonspecific. A good example is the case of ribavirin, which has been thrown at all kinds of viral diseases. And as a virologist in a former life, I've always been skeptical of ribavirin data. First of all, it's almost never translated into meaningful clinical benefit. What it does essentially is that it makes the cells sick and therefore decreases the virus yield. And so, again, I'm just a little bit of a skeptic just because I've seen some of these things. Other things that have been tried for COVID-19 infection that clearly don't work are lopinavir, ritonavir, which is a retroviral agent. And again, if you look at the cell culture, what are called IC50s, or basically the concentration of drug that inhibits 50% of virus replication, they're hundreds of times greater than its activity against HIV-1. And of course, when it was studied in a small prospective randomized trial, it was completely ineffective. So I think at this point, the best thing to do is to to really support these patients very aggressively. The drug, though, that I think is showing the most promise right now that I'm aware of is a nucleotide analog called remdesivir. And remdesivir, again, acts as a chain terminator as opposed to nucleotide analogs. And again, has a very potent micromolar activity in cell culture. And again, it's currently being tested in a couple of different prospective randomized controlled trials in both patients with moderately severe disease and severe disease, and then also as a compassionate use drug in patients who are too sick to qualify for either of the prospective randomized studies. So again, I'm hoping that we do have data really from all over the country at academic centers, and even community hospitals are participating in these trials. So again, I think that right now is, to me anyway, looking the most promising potentially for treatment.
Thanks. And eventually it's going to all come down to the vaccine, right? As we're sort of looking at getting control at the pandemic and you know, looking ahead at the end of the year. What is your assessment on the timeline for that?
Yeah, so again, you know, quoting my friend Dr. Fauci, you know, I think we're really looking at 12 to 18 months, you know, realistically, before a vaccine can be fielded. A couple of things to remember about vaccine, even if you know, show efficacy in short-term protective studies, let's say in non-human primates, and it looks like with this virus, and you know, maybe a reasonably good model based on, again, a very small study I saw just last week, but it's still going to require at least human testing, not for efficacy, of course, but for safety. And then you have to scale up production. And remember that particularly if it's a cell culture-based produced virus, or even a recombinant virus, that this is a very complex process to produce a biologic, and it's very difficult to scale up. So I think that's another reason why the timeline for developing a protective vaccine will be much, much longer than developing a viral agent, which again, like a nucleotide analog, is actually a very simple compound to synthesize and produce. You know, I always joke that Walter White, the character in Breaking Bad, could probably make a nucleotide analog effectively in his bathroom. So that illusion might be lost on our international members. But.
Well, I'll hold on to my comment for that. Thank you. Let's see. We had another follow-up question around. Well, there's a question about this drug and nitazoxanide, which I'm hearing for the first time. So I don't know.
Yeah, so nitazoxanide, you know, is a drug that, you know, we use for, you know, certain parasitic infections. And honestly, I am just not aware of data on that, yeah, either in vitro or in vivo. But again, you know, please feel free to send me the reference, and I'd be happy to look at it and respond to you by email. But again, that's the first that I've heard of it having either in vitro or in vivo activity. But again, you know, this is really a very rapidly developing field.
Mm-hmm. Okay. Well, of course, there's been a lot of concern around PPE, and you know, what's the right PPE, and how can we ever have enough of the right kind of PPE for every provider and patient interaction. So what's your take on you know, sort of the right level of protection that would be enough for healthcare providers that are all anxious with sort of considerations around sort of the need for enough N95s versus the surgical masks being enough, and so forth.
So again, I don't want to, you know, misquote these guidelines. And of course, we actually have guidelines, you know, that have been promulgated by other societies, as well as, of course, you know, individual hospital infection control or infection prevention organizations. But essentially what I think makes a lot of sense is what we're doing right now at Stanford, which is sort of, a graded degree of protection that basically contact with all symptomatic patients that, you do need, a higher degree of PPE. And certainly if you're in a situation where you're actually generating aerosols, that you'd have to have a much higher level of PPE, including not just a face mask and a face shield, which is, by the way, is very important, particularly if you're going to reuse the mask. It's important that the mask actually be covered with a face shield, and then of course, a gown and gloves and that sort of thing. And then again, for say for doing a bronchoscopy or some other procedure where you're actually generating aerosols, most organizations actually are recommending PAPRs, although that may not be necessarily something because of resources that you can do in all settings. So again, I'd be happy to share what our current guidelines are that we're using, but again, I think evidence-based, and I personally feel very confident that I'll be protected as I care for patients by following these guidelines.
Okay, and along those lines, there's a follow-up question I see, which they ask, so can we reuse the N95 masks?
So again, I think that there actually has been some guidance out there. So it's real important, though, of course, that that the mask be allowed to dry out. Obviously, if it's still moist, from breathing into it, it's not going to be nearly as effective. So it's one reason they're actually recommending that if you are reusing the mask, you actually do put it in plastic per se. For all really significant resource issues that we're struggling with, even at Stanford, which is certainly a blessed with resources, but we're very short of PPE equipment as well. So again, it's reuse as appropriate is going to be necessary in many settings.
I'm sorry if I missed the initial part of your answer. Can you repeat that when you said so you would recommend if it's moist, then let it dry, and did you say put it away for a little bit? Like, is there a timeline, like duration to let it dry, or before we use for a second patient?
Yeah, I don't have specific guidance on it. I think some of that is going to be kind of a judgment call. But again, though, I just was reading in our own guidance at Stanford that they are not recommending that you use it and put it right away into a plastic bag, which of course would prevent it from drying.
Okay. And we know there's a question around does the nasopharyngeal swab test for COVID produce enough aerosol, which in turn requires that the person performing the test wear an N95 respirator? And what's your take on that?
Could you repeat that question, Ankur? I'm sorry, I was trying to...
Yeah, it's around sort of the when the provider is doing a nasopharyngeal swab for testing, does that produce enough aerosol, you think, that one would need to have an N95 at that time just for testing?
Yeah, so I think again, someone who is clearly symptomatic, that probably is prudent to do. But I really like to just really emphasize that for everyone to go to this U.S. Centers for Disease Control website, to get the specifics of their recommendations for PPE. I think in theory, just doing a nasal swab wouldn't really qualify as being small particle aerosolization, but rather again, droplet precautions would be the thing that's most important. But again, just want to emphasize that I don't have all the guidance in front of me, but I really would encourage everyone to go to the U.S. Centers for Disease Control website to get their latest guidance, which is basically what we're doing at Stanford.
Mm-hmm. And there's again questions around healthcare professionals worried about taking infection home, and any practical tips to avoid that or to decrease the chances of transmitting it to their families and spreading?
Well, again, I think that the important thing is that if you're symptomatic, you should be isolated. And if you're not sick enough to go to the hospital, it, probably means, staying in a separate room and minimizing contact with other individuals in your family. I think the concern, though, about asymptomatic healthcare workers somehow bringing infection home to their family is not really shown to have been, at least at this point, very important of transmission. Remember, we talked about that you can show that, for example, the virus can persist on certain types of surfaces like stainless steel and plastic for a fairly long time, but there's no evidence really that you can get infected by this virus through intact skin. It's probably contact, let's say, between your hands on an infected surface and then, rubbing your eye or your nose like we all do unconsciously throughout the day. So I'm personally not too worried about, healthcare workers being vectors for their families unless they themselves have symptoms.
Mm-hmm. Okay, that's reassuring. Multiple questions around post-infection immunity. How long is one protected, or and so forth? Yeah.
So that's again a very important question that we really just don't know the answer to. There was a study that I was asked to review and comment on last week. Again, very small study from China, but it looked like very well done. They took 4 rhesus monkeys and experimentally infected them. And they showed, as we've seen, in humans, that virus shedding, peaked at about the 2nd or 3rd day of illness and then fell pretty dramatically. And they did demonstrate that all 4 of these monkeys developed neutralizing tissue culture that appeared to persist, but it was a very short-term study. And then day 28, following the initial infection, that they re-challenged the monkeys with SARS coronavirus 2, and none of the monkeys became secondarily infected, which I think is reassuring. But it still, begs, the question, like, number one, rhesus monkeys are genetically a little farther from humans, for example, than chimpanzees are, but chimpanzees are very, very expensive, difficult to work with, and very short supply. And then number two, it was a very short-term study, so we don't know how long this immunity is in monkeys, let alone in human beings. So I think it still begs the question whether reinfection is possible. My own hunch is it's probably very unlikely that reinfection can occur even many months later, but we just honestly, Ankur, just don't know that yet. And the last thing, of course, is that the presence of neutralizing antibodies that work in tissue culture may not necessarily correlate with what actually is a protective antibody in vivo, in the whole organism. So, again, I'm looking forward to seeing, as really smart people look at the immune response to this virus, actually looking at which particular epitopes that the different antibodies recognize as potentially being effective. So, I'm sure a lot of really good basic science is gonna come out of this.
Mm-hmm. Okay, that's reassuring to the extent we can we have information at this point that reinfection is hopefully less likely, and there's going to have some immunity. What about co-infection? There's questions around co-infection with RSV, influenza, especially in children or high-risk populations.
Yeah, so again, I think we don't really have enough experience to make definitive statements, but certainly co-infection with the SARS-CoV-2, has been documented. In some cases, it appears to be more severe clinical manifestations than people who are mono-infected. But again, my sense is that there really is just not enough cases to draw definite conclusions from. But certainly viral co-infection does occur.
Okay, so we cannot exclude the possibility. Okay. Are there any specific standards that you've heard of for precautions for patients with COVID positive going for surgery? This is from our neurosurgery friend in Bhutan. Yeah.
Yeah. So again, this is an issue that has certainly come up in the U.S. and a number of in Stanford have essentially canceled all elective surgery. So then the issue would come up, well, what precautions should be taken in the setting of someone, who is known COVID-19 or SARS coronavirus 2 positive and who needs, say, an emergency surgery, like bowel obstruction or something develops and needs surgery. So I would certainly think that, individuals who are involved, like directly intubating the patient, that may be exposed, to potentially small particle aerosols, should probably have, the highest level of PPE, whether it's a PAPR or at least an N95 mask with a face shield. It seems like that's prudent. But again, I'd like to refer everyone to the CDC website, and I think that actually some of those issues are addressed in the website. So again, I just don't want to misstate, one of those recommendations.
Mm-hmm. Sure. Thank you. Moving on to sort of general community spread and prevention, there's obviously sort of a lot of sort of messaging around social distancing and avoiding sort of close contact. There's the public sort of aspect, but then also sort of also as providers we're considered essential workforce. So there's some questions around concerns. How can we actually practice social distancing in these complex medical sort of scenarios with teams, with trainees, and sort of doing rounds or sitting in a reading room together and so forth.
Yeah. So, those are all really good questions, and they're all kind of related. So I'd like to just go back a little bit to the whole, like the scientific rationale behind the 2 meter or 6 feet distances we say, is recommended here. That again is based on the fact that these large particle aerosols, which we have the most evidence are the major means by which SARS-CoV-2 is transmitted. Even someone who vigorously coughs or sneezes, these large particles really don't go much beyond about 2 meters away from the person. So that's, again, the rationale behind this, the arbitrary, seemingly arbitrary distance recommendation. But you're exactly right. It's sometimes difficult to maintain that. And that's, I think, the reason why, one reason, that many places, including the state of California, have actually put these shelter-in-place orders just to have an extra level of protection. So the question in the medical setting again goes back to what's the relative risk. So somebody who is definitely known to be SARS-CoV-2 positive or COVID-19 positive, I think it's not unreasonable to have that individual wear at least a surgical mask while they're in the presence of a healthcare provider. The other thing that we're doing at Stanford, as I'm sure you're aware, is that patients who are either being ruled out for COVID-19 or who are confirmed to be positive, of course, are kept in private rooms with negative pressure airflow. And the providers actually, at least in patients who are stable and don't need necessarily to be seen hands-on, are actually having sort of Zoom computer visits, like we're conducting this this interview today. So again, there are other ways that can at least limit, but not completely eliminate, direct contact of providers with patients.
Mm-hmm. Thank you. Are there? This is a long question, but sort of general policy question, I think. Talks about, are there legitimate scientific reasons not to do everything we can to stop the spread of COVID-19? Is there an implicit suggestion in flattening the curve that our measures should be less than absolute? Is there an argument for some sort of managed herd immunity strategy, or should we have more widespread shelter-in-place orders immediately?
Yeah. So, again, those are to some extent, policy issues, but the couple of reasons, why people are recommending, the flattening of the curve, so to speak, is short term. What it does, even if the total number of people, let's say in the population, become infected eventually, but by flattening the curve, you're really dramatically improving the sort of the resiliency of the healthcare system to respond to it. So as I said, even with the relatively small number of cases that we have in the US, although by the way, the curve still does appear to be fairly steeply increasing, we're really, facing shortages of personal protective equipment. And another thing, which kind of goes back to the question about testing limitations, it's not just shortage of the RT-PCR test kits and reagents, but it's actually shortage of swabs to use to test. So there's all of these resources that are being stretched very thin right now, despite these measures taking place. So I think, again, hopefully by flattening the curve, we're also decreasing the total number of people infected, but more importantly, at least short term, we're allowing our healthcare system to kind of keep pace with this large number of patients who are getting sick.
Mm-hmm. Along those lines, as we prepare sort of for sort of the surge in some of the communities, even in our audience, we have sort of a global audience here, so we're all in different sort of timelines of that curve, and some places maybe one case to hundreds and thousands of cases now in U.S. cities as well. There are questions around preparedness. How can we better prepare ourselves as clinics or hospitals or ICUs? Are there any best practices we should be following, and any other resources that you would want us to look at?
So again, I apologize, I keep sounding like a broken record, but I think the go-to website really is the U.S. Centers for Disease Control website that I think really has very good, scientifically evidence-based, common sense guidelines that that really should be put into place as best as possible. I think they're doable, but again, we're running short of the PPE and some of these other things, even in a research-rich setting like the U.S. So again, I think that it's going to be a challenge, particularly in the developing world. Again, just hoping that perhaps in the subtropical and tropical areas that we don't see as efficient a transmission, as we're seeing right now, which is still kind of the tail end of winter here in the northern hemisphere. So again, that's an optimistic scenario, but I would certainly encourage people to really look at the guidelines real carefully and not to be wise, but you do not need to hoard toilet paper. It's not going to have a significant effect.
Or masks. Yeah. I know we talked about high-risk populations early on, and there are some concerns about pregnancy as well, as generally considered as being a higher risk state for influenza and other viruses. But any data that you've seen around this population?
Yeah, from what I've read so far, Ankur, is that pregnancy, obviously there is a risk, particularly in early pregnancy, infection with early fetal. There's no evidence, though, however, that the SARS-CoV-2 is actually teratogenic, as the Zika virus is and was. So I think that's a little reassuring. We do actually, though, have some limitations that we've put into place with pregnant healthcare workers, at least recommending minimizing their exposure to at least proven COVID-19 positive patients in healthcare settings. So again, it looks like it's not quite as serious of a situation as is with, as you pointed out, with influenza A, which of course pregnant women, both in 1918, 1919, as well as, at least I'm aware of more recently in the 2009 pandemic H1N1, that pregnant women had a much higher rate of very serious illness. But we're not really seeing that, at least to my knowledge, with COVID-19 at this point.
Okay, that's reassuring. And then we've got, I know there's questions around the timing of ventilator use and sort of in the setting of maybe not having enough resources as well. I know we're going to have some experts coming up from critical care space as well in the coming weeks, but any quick thoughts on that, Dean?
What's the question exactly, Ankur, again, about the later use?
Would you wait to extubate after the patient's negative or based on clinical improvement?
I think, again, that's a, certainly, someone who can be extubated, who meets criteria for weaning, I think they should be extubated promptly. Again, there's all kinds of potential adverse effects of leaving a patient intubated and, and sedated long-term. So, as soon as, again, you can, safely wean them off mechanical ventilation, you definitely should get the tube out, and there's no real advantage.
Right. Okay, well, we're coming up to the end of the hour. I know there's always questions we can't get to, right? Not every question, but we'll end with this one. It says, regarding wellness, everyone's obviously, whether it's public or us as healthcare providers, everyone's there's fear, there's panic, and a lot of uncertainty. And what are some of the things that can be done, or you would say, to offer support and encouragement to the community members or our community in general?
Yeah. So, again, I think some of those things are almost in terms of the answers, but, I know, personally that, I thought about many of these things, throughout my career, not just with SARS-CoV. So, again, I think just, my own philosophy is that, I'm grateful for every day, that I'm, I'm in this life, and, and it's wonderful to be part of a profession, the healing profession, and to be of service to my fellow man. So I think, just waking up every day and knowing that we are on the front lines and that we are really doing, I think, noble work in the world is really positive. I think, certainly, thanks for family and for hopefully other blessings that you have in your life is really important. I think it's also real important, you take care of yourself. And that means, physically by, say exercising outside, not in a crowded gym, but, going for walks, eating right and making sure that you are sleeping well, everything, is a lot better, when you take care of yourself. And that's not selfish. That's really what we should be doing, and we can be of better service. Whether you have, faith in something or not, it doesn't really matter. But I think just, it's the right thing to do, to care for yourself first and care for your families. So certainly encourage you to do that. And, those of you who are working, in these amazing settings, often without resources throughout the world, in my opinion, you really are truly doing heroic work. And, my hat's off to all of you.
Well, thanks a lot, Dean, and thank you for your work over the years as well, and in the service. You're really an inspiration, so thank you.
Okay, great.
We're coming to the end now. I'll turn it over to Bhavya and Bill and see if there are any final comments. And thank you everyone else for putting in their questions in the chat as well and keeping it interactive. So thank you for the engagement.
Thank you, Ankur. And thank you so much, Dean. We really appreciate you doing this for us. You've always been this inspiring force, not just in your profession, but also personally. So we really, really appreciate you doing this for us. And thank you for the comforting comment at the end for gratefulness. and every day, and which was very well said. We have already got a lot of thank you notes from different parts of the world who have been logged in for this webinar. They were looking for a reliable voice, and they felt comforted, and they felt their questions were answered during this session. So thank you so much for doing that. I just want to ask, I know Dr. Albert from Cameroon, if there are anything, I know you could not submit questions earlier. If there's anything which you would like to address right now, otherwise you can also send it to us by email later, Albert, is there anything?
Yes, back here, I guess that the residents might have some quick questions for Professor Winslow.
Okay, we can just quickly address them if that is fine. Dean, is it okay if we take 5 more minutes?
Oh, absolutely.
Okay, yes, Albert, please go ahead.
Good evening. I wanted to ask about animal transmission, animal to human transmission, or human to animal transmission of the COVID virus.
Yeah. So again, that the way, at least that it's been pretty well documented, that the virus was transmitted initially from wild bats, through pangolin and other mesomammals that are often sold in these wet markets in China. And again, how efficient that transmission is, I'm not really sure. But clearly, though, that this virus, once it got into humans, is moderately efficiently transmitted from human to human. The original, what they call R naught or R sub zero estimates were about 2.5 from one index case. So that's kind of on the order of flu, maybe a little bit less. It's certainly not as great as measles, which is something like a 15 to 1 ratio. But again, I'm not really sure at this point, since now the virus is pandemic and human to human spread is relatively efficient, how important at this point, zoonotic infection is. I'm not aware that certainly, the common animals that we're surrounded with in the US, like dogs and cats, I don't believe they can be efficiently infected at all with the virus.
That's a great answer. Albert, anything else? Okay, all right. And there's one more question from South Africa. I'm based in KwaZulu-Natal in South Africa. We have a population of 11 million people, and we are the epicenter of HIV. Are there any case reports on COVID-19 in HIV-infected patients? We also have high tuberculosis TB incidents, including drug-resistant TB. Are there any case reports on how COVID-19 will affect both TB and HIV patients? We are already in a resource-limited settings with a strained public health sector, so the pandemic can be catastrophic for our province. So we just wanted to ask this question. So Dean, the question is whether there is any case report for how COVID-19 would affect HIV-infected patients and TB patients.
You still there, Dean? I don't know, your screen seems to be frozen. Possibility that poor internet connectivity.
I think we also have a lot of users, so
we lost Dean for a second, so we'll wait a few seconds, see if he comes back.
Yeah, I think there are a lot of users, so we might be.
Yeah. In the meantime, I'm just going to share this with the audience that if you're able to see, this is our upcoming lecture for next Tuesday with a professor in virology from University of Iowa. And it's going to be talking about COVID-19 and the virus as well. So we look forward to have you all join us with the same login credentials next Tuesday, March 31st, 7 a.m. Pacific time. And you can all continue the conversation via WhatsApp and Facebook through to our groups. And if any one of you are not on either of those groups and would like to join, let us know at contact@healthfortheworld.org, and we can have you join us. And we can continue the conversation in those platforms, and have more questions for faculty. We can always send the questions. You can let us know those questions via those two avenues, and then we'll forward them to the faculty, our guest faculties, and then continue the conversation to help each other out and continue the learning.
So this is the COVID-19 Health for the World Global Physicians Group. And if you put that in Facebook, you'll be able to find that. And the good thing is we collect questions before the webinars. We have multiple interesting webinars coming up. So for example, this one by Dr. Winslow, multiple people from around the world were able to submit the questions beforehand and get the questions answered. So, and if you need a link to this group, you can also contact us at contact@healthfortheworld.org. All right. Albert, is there, I think Dr. Winslow, do you see him, Ankur, or I think he got locked in?
We may have lost him because of.
Hello, Ankur, can you hear me?
Yeah, Albert.
Yes, we can hear you.
Hello?
Yes, we can hear you.
Hi, hello?
Hi, Albert. Yes, we can hear you. We can hear you. Yeah, you can go ahead. Do you have a question?
Yeah, I just have a comment. So what is going on in places like Italy and China right now? Professor Winslow mentioned the drug remdesivir. I just want to find out, is this drug available? Are these patients in Italy and China being treated with this medication, or they're just getting supportive care with ventilators? Because right now in Cameroon, we have 56 confirmed cases of the COVID-19. And most of these patients are being treated with chloroquine. So I want to find out if remdesivir is a drug that is available and is being used right now, or there are other alternatives. Because right now we are counting on chloroquine or hydroxychloroquine in case we have suspected cases.
Yes, we can check on that. Albert, as per my knowledge, I think it's only available for compassionate use under trials, drug trials by the NIH in the United States. But I am not sure. Well, I do see Dean come back. Are you with us, Dean? Let me unmute you for a second. I think you're okay. Now you're unmuted. Dean, you can hear us?
I'm losing connection here in Silicon Valley. I think you probably have better internet in Cameroon.
Yeah.
I think the system got overloaded because so many people joined from around the world, so it crashed.
We had a final comment and a question from Cameroon, Dean, if you can address that. It was about remdesivir. Do you know if it's available outside the United States? Has it been used in Italy and China, where we're seeing the kinds of cases, or is it just under trials in the United States?
Yeah, I'm not really sure that's in the rest of the world, but I do know that they are ramping up production of it, at least to be able to supply the trials in the U.S. So I'd have to check with Gilead Sciences to see how available it is in the rest of the world.
Right. And so Albert said that they're sort of banking on the hydroxychloroquine is what they're using over there. So well, I know it's going to depend on what kind of resources are available at each site. And
there was a question about prophylaxis of using hydroxychloroquine. I know that some countries are using that right now. Is there any data for that, for prophylaxis?
No, there absolutely is no data either in animals or humans that's effective. As I said, my tendency is to be a little bit skeptical of the chloroquine and the hydroxychloroquine data just because of its kind of mechanism of action. But as I pointed out, that's really the reason why it's just so important to enroll patients quickly in prospective randomized controlled trials. And there are actually a couple going on, in the US anyway, and I'm sure in the rest of the world. So, I'm not trying to discourage people, but again, just know that that there may be adverse effects of drugs on someone who's already very sick.
Right, right. And Dean, there's one last question from South Africa, from KwaZulu-Natal. They said we have a population of 11 million people, and we are also the epicenter of HIV. Are there any case reports on COVID-19 in HIV-infected patients? Also, we have a high TB incidence, including drug-resistant TB. Are there any case reports on how COVID will affect TB patients? We are already a resource-limited setting with a strained public health sector, so the pandemic can be catastrophic for our province. So we thought we'll ask this question.
Yeah. So again, I think that was when my internet went down, was trying to answer that. I actually personally not aware of at least large numbers of case reports of patients co-infected with HIV and COVID-19 or SARS coronavirus 2. However, I think certainly HIV patients who do not have suppressed viral loads and have low CD4 counts would be considered, at greater risk for complications of this disease. Although I do not know that for sure, but it just kind of seems like, you would want to consider this patient to be particularly vulnerable, as you would say someone who's on doses of corticosteroids. In terms of TB co-infection, again, at least in KwaZulu-Natal and much of sub-Saharan Africa, that many of the patients with TB, of course, are co-infected with HIV. So I think that would be the main thing that I would worry about in terms of a immunocompromising factor that could potentially lead to more adverse outcomes in those patients. The other thing, of course, just to be aware of is that, at least in the US, rifampin is one of our components, of four-drug therapy. And of course, drug interactions with rifampin are notorious because it's a very potent inducer of cytochrome P450 system. So, you'd also want to make really, sure of other drugs that you might be using to stabilize that patient. But I think that's something that you deal with all the time in sub-Saharan Africa. So I'm preaching to the choir probably about that caution.
No, but thank you for the excellent answer. One of the questions from the audience is, would you please answer about whether multiple sclerosis patient should be considered as high-risk patients for COVID-19?
Well, probably they should, particularly if they're on either a biological.
I think we lost Dean. Just wait for a few minutes.
I think there's a similar question around a physician working amongst patients with low CD4 T cells, non-HIV infected, and does this place the physician at a high risk?
Okay.
I believe as far as the CD4 question, I think the risk to the physician is probably sort of similar to it sort of depends on the interaction and sort of personal characteristics, not based on the patient.
You can hear us?
Yeah, can you hear me?
Yes, we can hear you. Yeah.
We lost you for a second.
Yeah, I'm so sorry. I apologize again. Yeah, we were talking about, I think, about patients with multiple sclerosis, and again, whether you have to worry about them. And again, certainly if the patient's receiving treatment with a biologic response modifier, which we're using quite a bit in the US, or corticosteroids, I think they would be considered at higher risk for developing more severe disease.
Right, right. And I think there's one last question. I'm a 64-year-old MD working amongst patients with low CD4 cells, non-HIV infected. Does this place me at a higher risk? Thank you for answering this question.
Yeah.
So,
Well, so first of all, my first comment is, since I'm 67, if you're 64, that makes you a kid. My wise answer is no, you don't have to worry. You're still a young man or woman. Again, our CD4 counts do drop somewhat naturally with age, and that may or may not be one reason why people, us more experienced senior physicians, may be at a little bit higher risk. But again, I think you certainly have to really look at the overall risk. And there were a number of healthcare providers who got very sick in China. And as I said, I think you just have to balance the risk and benefit of going to work every day with with that. Again, I personally though feel very reassured by the PPE that we have at Stanford and the recommendations that are out there on the CDC website. So I wouldn't be overly concerned.
okay. All right.
Okay. Well, thank you very much, Dean. Once again, thank you everyone else for joining us, and we look forward to having many of you join us back again in the.
Great. Well, thank you again. It really was an honor to participate, and thank you all for what you do every day.
Thank you, Dean, and thank you from us, and thank you from so many physicians who are sending thank you notes right now. So we really appreciate this. Thank you so much.
My pleasure. Take care.
Everyone. Stay safe. Be well.
Take care.
Stay home. Take care.